Good afternoon, everybody. Welcome, and actually good morning if people are dialing in from the US as well. So welcome everybody to the second part of this event, Wearable Sensor Technologies, Health Challenges and COVID webinar. And this is to explore research undertaken with wearables to enable monitoring, exercise and rehabilitation in ageing communities. So for those of you who didn't dial in on Tuesday, we had a great discussion. I'm the Chief Executive of the Health Innovation Research Alliance in Northern Ireland, and that's a health cluster to facilitate partnerships in the innovation space to support an active environment for collaboration across academic, clinical research and business. And I hope that's what's reflected here today with the SENDoc project, and also through with the panel speakers that we have from industry and the clinical and academic space. And we have hopefully speakers from the US, although there is a storm in the US, so we may get Holly joining us, but we also have speakers from Northern Ireland, from Sweden and Republic of Ireland, as well as Kirsty Mannheimer joining us from the Northern Peripheral Arctic Partnership in Copenhagen. So I'm delighted to co-chair again with Professor Joan Condell from the School of Computing, Engineering and Intelligent Systems at Ulster University. Joan's just going to introduce the programme, two excellent speakers, as well as Kirsty Mannheimer from the MPA, and then I'll follow up with the panel. I'm excited about that panel as well. So Joan, if I can hand over to you, please. Excited to hear your thoughts.
Okay, so thanks everybody for attending our second webinar. We had our first webinar on Tuesday where we looked at rehabilitation and monitoring of frailty using wearable sensors, and today's is looking at exercise using wearable sensors. So the SENDoc project is considering wearable sensors for the support of independent living in ageing rural communities across the Northern Periphery and Arctic programme. So the Northern Periphery and Arctic programme are an Interreg programme, and they funded this project. The project runs from 2017 to 2021, and we have a core partnership of 4 regions here. So Northern Ireland, we have Ulster University, who are the lead partner. We have Umeå University in Sweden and Västerbotten County Council. In Cork, in the Republic of Ireland, we have Tyndall Institute in UCC, and in Finland, we have Karelia University. So the aims and objectives then, the basic aims and objectives here were to introduce wearable sensor systems in ageing communities, as I said, to support independent living. So we want to try to keep ageing communities in their homes as long as they possibly can. And the project sought to assess the technical, clinical and social acceptability of wearable devices in this regard. So how would it impact patients? How would wearable sensors impact healthcare delivery, and also then the actual communities themselves? And as I said, we have 4 core partners here, and all of these partners are from different expertise. So we have computing in Ulster, we have clinical in Västerbotten County Council in Sweden, we have technical engineering in Cork in the Republic of Ireland, and we have physio experts in Finland in Karelia University. So today we will have members of the Ulster team presenting what we have done in the SENDoc project, examples, and we will also have Antti from Karelia presenting the physio side of things from Finland. So James, if I can hand over to you and you can show us the video, please. The SENDoc project is a European project. It's a Northern Periphery and Arctic Interreg project. We started the project in 2017 and it completes the end of this year, 2020. So it's a 3-year project and it involves 4 main partners. A physio partner in Finland, a clinical partner in Sweden, and a technical engineering partner in Cork, as well as ourselves in Ulster. The core aim of the project is to test mobility, strength, balance, and also well-being and exercise through sensors. can we use sensors to measure all of these things to support independent living?
When the project was initially written up and developed, it was thought that there would be one sensor system developed for one particular condition and distributed to all the partners. When we started the project quickly evolved into working on multiple demos, multiple conditions, multiple technologies.
We have tested so far 17 different sensor systems that are connected to elderly persons' independent living. And we have a certain protocol where we test the accuracy together with golden standard equipment that we have. And the next step, if the system is shown to be accurate enough, we have tested them in real working life rehabilitation processes, both in clinics, in-home rehabilitation teams.
Our unit at Västerbotten in Sweden is a test bed. We are doing a lot of testing, trying to develop better technology for care closer to the seniors in their homes. We have been looking at the frailty aspects and mostly on the risk of falling and risk factors for falling and how to measure them with connected health.
We have noticed that the sensors are not in the standard that we thought that they will be, but also we noticed that maybe also many things have to change in the hospital and in the healthcare service delivery model, because you need to have, for example, training to patients and to staff members. They need to know how to use these sensors, how to interpret these sensors, and they need to know where to put them so they can have repeatable measurements.
When developing this kind of activities and equipment, there has to be very close cooperation with computer engineers, computer scientists, and us rehabilitation staff as an end user.
As engineers and as scientists, you sometimes can be in a little box and not think too much about the users and actually what you're making can actually be being actually used for. And of course, as an engineer, the chance to test so many technologies with real users, and in particular get some of our novel technologies out of the lab in a real life setting, like with real users, and finding out the good and the bad from our technologies.
It's fantastic to be able to join in the project because it's interdisciplinary. We are meeting colleagues from 3 other countries in other specialities. I think it's in the crossroads between the disciplinaries that the magic happens.
Okay, thanks, James. So, clicking. Right, I'm going to summarize where we got to on Tuesday. So on Tuesday, we had our Swedish partners and our Republic of Ireland partners presenting a sample of what they have done in SENDoc. So we had Anna, who is the director of the Life Medicine Clinic in Umeå, and she has said that the SENDoc project has accelerated healthcare transformation in her region. Typically, they're risk adverse. They always need evidence and they need to show a need to make a big change. So Anna particularly focused on falls prediction and the mortality risk of the elderly in their own homes. And she has gathered data of over 6,000 70-year-olds in this project, which is exceptionally valuable. In Anna's perspective, acceptability is good for wearables in her region. Obviously, usability is a huge factor for success. So then we had John also on Tuesday, who discussed the Parkinson's demo that they have done in Cork with St Finbarr's, and Suzanne is on our panel today from St Finbarr's, so she may allude to that a little bit. And John said that there's over 9,000 in the Republic of Ireland alone with Parkinson's, and they have very infrequent clinic visits, so they can have maximum 2 visits a year, for example. So you can see how wearables and remote monitoring could really help these patients. They had one test where they had 20 patients in St Finbarr's, and they were testing hand function through a set of exercises, a predefined protocol. And John has showed that there is potential for remote monitoring of Parkinson's using wearables, but the wearable system needs to be integrated with the overall clinical care. We also had a panel on Tuesday. We had representatives from a company in Northern Ireland, Cradle, the Dial Centre in Derry, which is a training centre but focuses on ambient and wearable sensors. So they have a specific environment that is set up to test and trial and train OTs and other clinical staff in sensors. Be Secure, which is another startup company, and Corelli University, we had Elena, who was a physio. And I've just put on here some comments that we took away from that. So we all know there's been an explosion in wearables. Some of our panel members discussed how the speed of translation of these wearables into the home environment has been quite slow, especially in the mid-range wearables. But certainly when we look back at this year, COVID has accelerated this adoption. We really, really need wearables adopted for remote continuous healthcare. Certainly in Northern Ireland, pre-COVID, about 2% of GPs were doing calls. Now it's 99%, certainly in my area. It's really difficult to get to see a GP. All of your care is done via the phone or video calls. So there's a job of work to be done to make wearables acceptable. And a lot of that is down to trust, usability, security of data, etc. We all know in Europe and globally, we have a growing aging population. But what we find through SENDoc, through testing wearables with elderly groups, that they're very positive and they're open-minded. So age really isn't relevant in this regard. We may perceive that it is, but actually we have found that it isn't. We need to integrate wearables into the mainstream clinical system. And as I've said, usability is very important. Battery life is very important. Ergonomics, wearability, how fashionable the device is. Paul on Tuesday said that old people don't want to be walking around with some strange looking device on their arms as if they've just been let out of prison for the day. So it needs to meet the needs, fashionable ergonomics, wearability for the category of users that are going to be using it. We also talked briefly about training and competencies. So clinicians and people who work around that area need to be aware of what's available and the package of products. They also need to be skilled and trained in both digital and soft skills for motivating patients to complete and use the wearables. So we have a collective ownership, if you like. So the SENDoc project, this is the website, and it is funded through the Northern Periphery and Arctic programme, as I said. You can go online here and you can watch back the webinars. And there's lots of outputs, results, publications, etc. on here. So I'm going to, in a minute, introduce Kirsty from the funder from Copenhagen. I'm delighted she was able to join us today. But just before I introduce her, I'm going to give a little bit of background in that SENDoc contributes to the NPA by proposing new models of healthcare service delivery with rural communities. We aim to deliver effective services to change in age in rural populations. So increased aging population, how can we make our health service more effective? And we enable novel approaches to meet patients' needs using innovative technology and platforms, mainly focused on wearables, obviously. So Kirsty, if I could hand over to you now, please.
Thank you very much, Joan, and thank you for the opportunity for me to say a few words. I will try to share my presentation with you. Hopefully you can see this.
Yeah.
Great. I will give some very brief information. To start completely from the beginning, the Northern Periphery and Arctic program is an Interreg program. This is a European territorial cooperation program funded by the EU's cohesion policy, and it's funded through the European Regional Development Fund. And there's 3 types of Interreg programs: cross-border, transnational, and Europe-wide. And we are a transnational program, one of 15. And this is our program area, going all the way from Finland, Sweden, Norway, Scotland, Northern Ireland, Ireland, Faroe Islands, Iceland, and Greenland. So really from the Finnish-Russian border to the Greenlandic-Canadian border. and we even have some partners from Russia and Canada and even further afield. This is a vast program area, but what all the countries share, the regions in these countries, is that they have a low population density, they have a long distance to market often, an abundance of natural resources, but also a fragile climate, and there's also demographic challenges. It's quite an old population compared to the rest of Europe. And so the projects in our program are cooperating to address these challenges that they share, and also to take advantage of the opportunities that they share. I have some numbers here, but the main thing I wanted to indicate is that the program area is enormous, mainly due to Greenland. It's about 3 million square kilometers compared to the entire EU being 4.4. So, but it's a very small population, about 7 million, and this means that the population density is very low, below 6 people per square kilometer, and that's really quite unique in Europe. We have 4 priorities through which we address these common challenges and opportunities. We have innovation, entrepreneurship, energy, and mainly renewables and energy efficiency. And then the 4th one is natural and cultural heritage. And the most important one for today is that we have in innovation, we have a specific objective dealing with increased innovation in public service provision. And this is where the SENDoc project falls. As you can imagine, these long distances and sparse population are really require good solutions in terms of public service provision, but the NPA area has good preconditions for this. We have, in general, good internet connectivity, not in all parts of the program area, but there's the general condition compared to the rest of Europe. And distance spanning technologies are widely used. And also we have good regional innovation centers. And typical NPA projects using disruptive technologies are e-health and social care projects, e-government. And then we have the use in SME support, as well as energy management. And maybe to wrap up, we're currently dealing with the funding period from 2014 to 2020, even though projects will continue for a couple more years, but we are basically close to the end of the current program period, and we've allocated approximately 96% of the program funding. So there's some small amounts of funding left after having funded 58 projects, SENDoc being one of them. So we're, for the remainder of the program period, focusing on smaller project calls. We had a very special call earlier this year, the COVID-19 response call, which Ulster University and maybe some others of you have been involved in. This was a response from the program to a spontaneous initiative, which was the sort of formation of a response group, mainly starting with e-health projects and those who have been involved in e-health projects. And this was really the brainchild of Dr. David Heaney, who sadly passed away in the summer. But basically the group has grown and has expanded in terms of geography and also in terms of discipline. So it's now approximately, I think, 140 people. And they are looking at different aspects of the COVID-19 pandemic and its impacts and comparing responses in different fields. And I know Ulster University is involved, among other places, in the technical solutions and comparing this. So this has been a very valuable piece of work, and the projects are running until early next year. And we're looking forward to seeing what comes out of that. And then we're launching next month a clustering call for main projects. We haven't really announced it yet, so this is sort of a premiere. And we will later next year, probably in the second half of next year, launch a preparatory project call for projects targeting the new program, because we're at the moment in the middle of the preparations for the next funding period. And there's still a lot of things that are not yet decided or unclear, including the program geography, the budget, and also the themes. But we are discussing One of the themes of the new program will be a smarter Europe, and the benefits of digitization for citizens will definitely be one of those. So that's probably the most relevant theme in terms of the SENDoc project. So this is what I wanted to say for now, and I would like to hand back to Jen. Thank you.
Okay, Kirsty. So I'm just going to introduce our two speakers. So we have some of the Ulster team are going to present short bits of what we've done in Ulster, and then we'll pass over to Antti from Finland for the physio perspective. And we will see if we can answer questions after each speaker. So if you have any questions, I should have said this at the start, if you can put them in the chat, then we'll pick them up and we'll put them to the speakers when they finish. Then after the two speakers, we'll move to the panel session, which Joanne will chair. Okay, Daniel, so over to you.
Thanks very much, Joan. Hi, everyone. Just trying to share my screen here. Can we see that okay, can we?
No.
No? What was that? How are we doing now?
Yeah, that's it now.
Great. Okay, so I'm going to talk just for a little bit about what we at Ulster have done as part of the SENDoc project. So just a very brief overview of Ulster in case those are joining from elsewhere and don't know about it. So Ulster was one of the biggest universities on the island of Ireland, with about 5,000 students and about 2,500 staff, and there's 4 different campuses in Northern Ireland, spread across between Coleraine, Jordanstown, Belfast, and then Magee. And we mainly are based the SENDoc project out of the School of Computing and Engineering and Intelligent Systems in the Magee campus in Derry. And out of that school, we have, I suppose, a lot of research happening out of the Intelligent Systems Research Centre. I suppose there's a lot of different research happening themed around robotics, cognitive neuroscience, health, data analytics. And I suppose the SENDoc project kind of sits in the middle of that in terms of data analytics and health-based research. So,
Daniel, sorry to interrupt, you're in presenter mode, I think.
Yeah, I can switch that actually, sorry.
Thanks.
I'll switch that around. Is that better now, yeah?
Yeah, that's
Great. Okay, so I suppose that's just the intro anyway. So today's talk, we're going to have 3 different speakers from Ulster, myself, Richard and Carla, and each of us are going to talk about a different study that we conducted as part of the SENDoc project. And I suppose the theme across the 3 of these studies that we're going to talk about is looking at wearable sensors and how they can be used within a clinical context, and how we can extract information from these sensors to give clinical meaning. I suppose the real tricky thing is to consider wearable sensors. There's so much out there. There's so many wearable sensors that we can use. There's so much information that can be extracted from these wearable sensors. And the real difficulty now is actually trying to figure out how to use this data to give this information to clinicians so that they can make informed decisions. And so what we need to do in the middle of all this is actually do some smart data analytics that we can extract the relevant information for the clinicians so they can make correct decisions. And I suppose SENDoc being unique in that we have this mix of expertise on the project. What I've really learned from a computer scientist and a data scientist point of view is that usually we would start on the left-hand side of this process, then we would choose our sensors and try to figure out what algorithms would work well with those sensors. But working through SENDoc, what I've kind of realized is we need to start on the right-hand side of this image and look at speaking with clinicians and physios and figuring out what is the information they need first of all, and then working backwards. What is it that the patients needs? What are the requirements that the patients have recording this data, what is that they want in terms of a wearable sensor, what can they use in their home or in their clinic, and work backwards again through that, and then try to select the analytics and the sensors that suit that scenario. I think John mentioned this in the video, is that you can kind of be in a little box as a data scientist or an engineer, and you can focus on the cool tech or the cool hot machine learning that you want to use. But I think the really important part for SENDoc that we've learned is you have to start with the clinicians. You have to start with the information that can be used and what they need. And that was kind of the real thing we learned as we're going through this. So we're going to just talk about 3 of the different studies that we did as part of this project. And the first one is going to be on full body motion capture and some exploratory work happening there. And Ricky's just going to talk briefly about that. So Ricky, if you want to jump in there.
Yeah, thanks, Daniel. Thanks for that introduction. I think that's a really good point you're making about us coming from the technology side and then across into the clinical meaning rather than the other way around. I think this work here sort of highlights that sort of bad approach, if you like, in a way, that it's sort of taking some cool technology and seeing what we can do with it rather than feeding back from it the other way. So this work here is really looking at wearable technology for gait analysis, and particularly within the stroke cohort. So this is the XSense system that we've got on this project. You can see here it's quite involved and quite sensor heavy. If you look at that left-hand image there's about 17 inertial motion units that can be placed on the body. Typically, they've designed the system so that these units are placed on the more bony parts of the body, so that skin artifact on movement isn't affected as much, and so we can get good accurate data. You can also see on the images on the right that there's some insoles here as well, smart insoles, which is another technology we can use to capture some gait information. There are other sort of technologies you can use as well, like EMG and so on as well, which is measuring muscle activation through sensors there. But we have just started to really just look at the body motion for now, and even just neglecting the insole data coming from plantar foot pressure as you put your foot through the floor. I guess the big advantages for these systems is that they are very flexible in terms of where you can take them. So you can put these in a bag and take them on a plane and kind of go anywhere with them. You don't have to visit a bespoke lab with a lot of infrastructure in it. So you can take these sensors and apply them to lots of different contexts for gait. For example, you might be doing a gait study on stairs, or you might be doing a gait study on different terrain, gravel or whatever it happens to be, or with different footwear. And these systems are very, very flexible that way. I should say that this is a very research-based system. It's not something that you'll buy and take home and use it in the home. And that's really the main disadvantage with these at the minute. This is really at the research stage, trying to figure out what we need and what the data looks like and what we can do from there. So you want to go on to the next slide, Daniel. So what we did as part of this work was essentially collect a lot of walking data. So we know that walking therapies are supported by the NICE guidelines for stroke, for example, for stroke rehabilitation. So we're just solely looking at walking therapies for now. We collected a series of walks on treadmill at 4 different speeds. We give people the choice on the third walk down there between 3.6 and 4.5 kilometers. That is a sort of comfortable speed, whichever one you feel is more comfortable. So a sort of more natural walking speed, was the other 2 are very slow. Obviously 1.8 and 2.7 are quite slow. We included those because of the elderly population that we also want to target this at. And those are more comfortable speeds for the elderly population, so that we have a good representation of, the large cohort being represented. We also recorded some turning information as well, and over the ground walking, as we often find the difference in the gait parameters coming back can vary depending on what it is you're walking on, as well as your gait. So if you're walking using a treadmill, often that can be quite assisted gait in a way. And that can lead to very low variation in gait. Whereas if you're walking over the ground, there can be a lot of more normal gait variation, which is good to capture as well. And we also capture some turning information as well, so how you handle the sort of turning as well. Okay, so that was the methodology, and we could have collected, as Daniel said, from these sensors you can collect a massive amount of data and look at lots of different features. Here we just looked at knee angle versus the angular velocity of the lower leg. What we get from these is a sort of lovely phase portrait that works in an anti-clockwise sort of fashion here. And you can see, I should have probably labeled these up a bit better, but you go through, the heel strike is that sort of smaller, sort of heart sort of shaped profile there. Yeah, where Daniel's highlighting for me, that's kind of where the heel strikes. And then if you go clockwise from there, that's when the heel is on the floor, and if it's on the floor, and then the swing phase is when it releases almost and goes right round again. And you can see we can plot these per person for the healthy cohort. And in this graph, you can see there's 2 walks that have taken place from the same participant. So a sort of blue walk and a red walk. And every single time you go around one of these phase portraits is a gait cycle. So it's kind of one step. So you can see here we've captured a 2.5 minute walk, or 2.5 minute walks, and placed those plots on top of each other to see sort of the consistency, first of all, of the technology, and then again the profile that you would get to indicate what that person's gait looks like. So that we did this for all 6 participants, and we had 2 elderly participants as well included in the study. And then we were able to compare these at different speeds. So this is the fastest speed at 5.4. And what we found, obviously, as speed decreased in this case, because that's the fast speed you're looking at, these graphs, those phase portraits, would decrease in size. And this final graph here shows that relationship between the area inside those phase portraits against speed. And you can see, obviously, you would expect a linear relationship there is what we've got back from that. But perhaps what you might not expect to see is that each person has a sort of different relationship, and that green one at the bottom, for example, is a very efficient way of walking, as it resulted in a sort of lower area of phase portrait, which means they were going through lower angular velocity and lower range of motion as well, but still able to maintain that speed even though they were having lower parameters there. So I think it's quite useful to look at that as one parameter essentially. And the idea overall would then be to have a normal distribution of these versus someone who maybe is rehabbing from having a stroke, and seeing how that compares with this data, and basically show them how they respond to that data and how close they are to normal, and the progression back to maybe hopefully getting back to these kind of numbers. So that's everything from me, Daniel.
That's great. Thanks very much.
Happy to take questions at the end or now in the chat.
I think we'll just keep going on, and we'll jump into Carla's talk now. So Carla's just going to talk about another type of sensor on a different patient cohort and some of the things they discovered during that. So over to you, Carla.
Thank you, Daniel. Thank you, Ricky. Okay, so as Daniel and Ricky said, well, this study focused on people with axial spondylitis that have arthritis in the spine. And the highest prevalence of spondyloarthritis was in 2016 in North America and Europe, with 1.35% and 0.54% respectively. This is people that has problems of mobility in the spine. They have a lot of pain, they cannot work, and sometimes even cannot walk or sleep. So when the disease is to progress, so a key outcome to measure the mobility of the spine or is that is highly variable and subjective when assessed using conventional tools like the goniometer in this picture. So we have cervical rotation is the only movement test measured in degrees in a test that calls BASMI. So the aim of this study was to evaluate the reliability of inertial measurement unit sensors, attained measurements from movement tests performed by patients with axial spondylitis against measurements attained from conventional metrics like BASMI, that is the truth dimension of the Ormeract filter. We have that for next slide, Daniel, please. Thank you. For this study, we have that we use dorsal V-move sensors. These are IMU sensors, accelerometer, magnetometer, and gyroscope. We have 40 participants of axial spondylitis on Alna Galvin Hospital. This research, the success of this research is heavily invested in the research nurses based at Alna Galvin Hospital. We have that the severity was in these participants and a mean of 13 years of disease duration. Sensors were put in the lumbar level in between T12 and S1 bony landmarks. And this was using adhesive and height templates that allow us to put the sensors and the participants in the same places. And at the level of cervical level at occiput and T3 in the next picture in the right. So back and neck movements were monitored and recorded, plus patients recorded outcomes and conventional metrology. Next slide, please, Daniel. Thank you. So our protocol was to review the inter-rater and test-retest reliability within 2 weeks gap between tests. And these were performed in a sequence. So for example, in day 1, we have one of the nurses doing 2 different measurements of participants at different times, putting and removing the sensors. And also we have in the same day 1, other nurse will take a tear measurement and we'll put again the sensors and remove them. And then in day 2, one of the 2 nurses will come again and take measurements of the participants. So lumbar and cervical angles were attained and analyzed using interclass correlation coefficients. And we attain maximum range of movements for anterior flexion, extension, lateral flexion, left and right, and rotation left and right for cervical and lumbar regions. And the 6 values were employed to calculate the IMU-ASME composite score. That is a score that was researched and validated previously by researchers in Spain, collaborating also in some part of the project. And we have that Pearson correlation with BASFI were calculated. Next slide, please, Daniel. Thank you. So the results were that sensor tests show excellent reliability for cervical rotation, side flexion, lumbar flexion, and cervical flexion with values of R equals to 0.85, 0.84, 0.62, and 0.63 respectively. The mean BASMI was 4.8, ranged from 1.2 to 8.4, and the mean IMU-ASME score was 4.0, from a range of 0.1 to 9.3. And the correlation between BASMI and IMU-ASME was 0.88, which was pretty good. So the correlations between BASFI and BASMI was 0.68, and between BASFI and IMU-ASME is 0.71. So both intra-rater and inter-rater reliability were excellent. So it means that doesn't matter which nurse put the sensors, the measurements were very reliable, and even doesn't matter the days. The measurements were consistent with using the sensors. So IMU sensors can be used to measure the disease accurately in progression. And also we can measure them from one day to the other. It doesn't matter which nurse takes the measurements. So that is all, and I will pass now to Daniel.
Thank you very much, Carla. That was nice. So that kind of shows really that wearables can be used in a clinical setting quite well. And the final study we're going to talk about, and I'll just talk about this, is when we use the wearable sensors at home rather than in a clinic. And I suppose the particular problem we're focusing on here is fall risk. And we know from stats that falls are a big problem. They affect a lot of people over 65, and they cost the health services a lot of money in terms of treating and managing that. So fall risk assessment is a key way to identify those people who are at risk, and then provide particular therapies or treatments or home modification to try and reduce that risk. So there's a number of different ways that are used currently to try and assess that risk, but each of those ways have their weaknesses, and it means a lot of people remain unidentified that are still at high risk. So what we want to try and do here is figure out, can we use wearable sensors in the home to try and continuously assess a person and identify people at risk. So what we used for this was our collaboration with our partners in UMEA, and Joan already mentioned this already, and Anna mentioned this on Tuesday. They have a huge data set of up to 6,000 participants. Now we've looked at a subset of that data set using 1,700 participants, where those participants took a wearable sensor worn on the hip in their home for 1 week. And 12 months after wearing that sensor, they were followed up with and asked to recall if they fell during that 12-month period. And so of those 1,700 participants, we found that 262 of them reported a fall during that 12-month follow-up. So I suppose there are two things to consider here. Number one is, does wearables work, but also what are the existing standard measures of falls risks like, and how did they perform when compared against this 12-month follow-up? So one of the big ways of assessing risk is to look at fall history and assess, has that person had a history of falls, and therefore anyone that has a history is of higher risk. So of the participants in the study, 525 of them had a history of falls. Of those that fell 12 months later, only 23% of them came from this 525 set. So in other words, 23% of this 500 had a future fall, and 77% of this 525 did not have a fall in the 12-month follow-up. And I suppose from the other side as well, people that had no fall history, there were still 14% of those had a fall in the future. So fall history doesn't necessarily work as a great, it's pretty good, but it doesn't work as well as some other measures. So there's other measures that can be done, and again, if you look at the literature, these are common measures that are used to assess risk, and there's things like timed up and go and gait velocity and grip strength, all common measures used to assess risk. Those measures do show some level of correlation with prospective falls that happen in the future. So what we wanted to do here, and I'll just do this very quickly because I'm conscious of time here, is that we got the participants to wear the accelerometer for 1 week in their home. And the nice thing about this now is that they just wear a sensor. They don't have to come into a clinic and perform a set of tests. They don't have to be monitored by a particular expert. They don't have to be supervised, and they don't have to be trained on how to do any particular test. They just wear a sensor on their hip using a kind of a belt mounted strap. And then from that data, we then extract automatically measures of gait quality, of the gait shape of particular steps. And we look at some frequency domain measures in terms of the frequency of particular walking bouts and extract some features from that. And I suppose as a very quick summary, what we can do is we can look at really, really simple threshold classifiers like fall history, timed up and go, and gait velocity. And you can see that the sensitivity and specificity perform okay. But if we introduce machine learning based models, and we use a machine learning model based on things like timed up and go and gait and so on, we can get a sensitivity and specificity again around 0.56, 0.58. But using just an accelerometer in the home and nothing else, we can get a sensitivity which matches those tug and gait measures, but you also get a specificity which is significantly higher, meaning you're ruling out false positives a lot. You're not falsely identifying as many fallers as these other methods do. So I suppose in conclusion, and conclusion of all the three talks, what we're seeing is that wearables are really useful for clinicians to help them make decisions on certain treatments. However, what we're seeing, and again, this is a theme that's coming up a lot now, the adoption in real world settings, in real home remote settings is poor at the minute. But these wearable sensors really do work if designed correctly and provided the correct form factor and so on. So what I'm going to do now, rather than me talk about these additional barriers, I think Antti is due to speak next, and I think he's probably going to talk about these additional barriers much better than what I will. So what I'm going to do now is just introduce Antti, our partner from Finland, who can take over and speak about his about his findings.
Thanks, Daniel.
Okay, greetings from snowy Finland and greetings from Santa Claus. He lives 600 kilometers above us. So I met him just yesterday. Hope you can understand my Finglish, which is not very good. I'm speaking from very practical point of view because we have used some sensor systems very much in actual older persons remote rehabilitation systems. So my lessons learned are very practical. But few words from our university and where we are from. So as you see, we are the area in eastern Finland, just beside the Russian border. We are mainly lakes and forest, but as you see the picture below, that was of course taken before Corona. The people gather around time to times. The city that we live is, there is about 76,000 inhabitants, and in this region about 150,000 inhabitants, and growing old very fast. We are a small but flexible university. There is about nowadays 4,000 students, about 300 staff, and we have both master degree programs and bachelor degree programs. In Finland, there is so-called dual model higher education system, but I won't go farther there. Considering our size, we have quite vivid research, development, and innovation activities. The amount of projects that are participated per year is approximately 70 to 80 projects. The volume is about 10 million euros, a little bit more or a little bit less depending the years. And our main focus areas are modern welfare services and then in the other hand sustainable energy and materials. But that about our university. Well, I must say that our university has rehabilitation service unit, which we have used a lot while testing these wearable sensors, and especially in concrete rehabilitation processes. And we have a good cooperation with our regional social and healthcare services provider organization. Concerning COVID-19, the need of remote rehabilitation in Finland has grown exponentially. But in the other hand, we have found in legislation instructions that there are certain loopholes that has to be fulfilled and corrected. This work has been going on all the time, and probably will continue. They are mainly instructions concerning connections and what level data security there has to be, etc., etc. Well, lessons learned number one is this data security, and maybe there should be this connections or wearables in the same topic. I don't know if you have the news has spread all over the world, but in the October here was huge information leakage of patient data in one private psychological rehabilitation unit, and the hacker blackmails both the patients and the organization. And actually, yesterday there was news from Organization for the Review of Care and Health Apps that today worldwide there is about 400,000 different digital health apps that are used in both healthcare and rehabilitation. And this organization's analysis said that only 20% of those fulfills the demands of data security and accuracy. Well, in Finland, there is defined certain levels of data security that are needed, and after the COVID loopholes, the minimum level being private or public has to be level B in the future. Well, then the actual remote rehabilitation processes, one thing that we have learned is that one key factor is the interaction throughout these web-based connections. You have to choose right rehabilitee who is able to use those equipment. And well, I have 40 years experience in therapy and 35 years of experience of teaching. You have to choose also right staff to take care of that activity. So there is also some research work that has been published that have enlightened also the same lessons learned that we have made. So especially when you working together with older persons, there is issues of functional capacity and sight and cognitive level, etc., etc., etc. Then interesting part what Daniel and Ricky and John yesterday mentioned is this accuracy aspect. For now, we have tested 22 different sensor systems, and according literature, the accuracy, reliability, and repeatability has to be 0.9. But validity, it seems that many of the sensor systems are so that some of the parameter that they read or measure or monitor can be very accurate, but some others are not so accurate. For example, sleep analysis, the accuracy of the whole sleeping time might be good, but analysis of sleeping phases is not good. Same with walking or gait or ground forces in it. It might be that the peak ground force is very good, or the gait speed is very good, or the cadence might be very good, but then some other parameter is not so good. And concerning the validity, it's not so obvious. It depends, can you use the wearable sensor in certain situation? For example, if you have a operation of knee or hip and you have limited how much weight you can put on your foot, then if the correlation of golden criteria is 0.9, there can be still 10 kilos difference in how much weight you can put on your foot, and that might be a risk of several things. So I think that the users have to be aware about those aspects of every sensor system. Well, then this usability aspect has been up for almost every speech, and there is this famous Nielsen model from '93 that is used in very many research and literature. In our opinion, there is one point missing, and that is the context. Is it used in home? Is it used in clinic? Is it used in remote circumstances? Should the person be able to use themselves, etc.? So you must always think the usability in the context where it is planned to use. Then the lessons learned 5, we have found out that there has to be agreed support team or support contact for both rehabilitation professional and the rehabilitee. In Finland, probably the next step will be, that is mostly used, is so-called hybrid model, where there is combination of face-to-face meetings and remote meetings. I can tell that in this region, the local public rehabilitation service provider has decided that in next 2 years, all when you think about outpatient physiotherapy activities, 60% of those will be remote activities, and 40% of those are face-to-face activities. So it will change rapidly in next few years. Well, last thing is that the actual cost effectiveness studies or research, there should be done a lot of more of those. We don't know very much. We know about direct expenses, changes in the functional capacity, quality of life, but cost effectiveness is in wider perspective in remote rehabilitation is still a bit question mark. Well, this was my 15 minutes, and questions can be asked later. So thank you very much, and hyvää joulua. It's Merry Christmas.
Thanks, Antti. Okay, Joanne, I'm going to hand over to you for the panel, to introduce the panel.
Fantastic, thank you. And thanks, Antti, Daniel, Carla and Ricky for your talk. I think we're going to move if there's any questions. I think some have been answered in the chat. But if there are any other questions, please put them up. We'll try and get to them. If not, we can make sure that they move forward perhaps for a future event or can be asked offline. So yeah, I'm delighted to start the panel, and I believe, yep, Holly's here from the US, so the storm hasn't got you, Holly, so that's good. So I'd like to introduce Dr. Holly Parker, and I'll ask her to introduce herself in a moment, Professor Peter Nordstrom, Professor Susan Timmons, and Dr. Jason McEwen as well on our panel. And in the interest of time, I think I'm going to hand over to you. If we start with Holly, if you'd like to introduce yourself and I guess your interests in this area, please.
Yes, good morning, everyone. Greetings from Maine, where it is snowing very hard and is very windy. So if I suddenly drop out, the storm has gotten me, but hopefully we can forge ahead. My name is Holly Parker. I am the Associate Provost for Strategic Initiatives at the University of New England. I'm also the Director of UNE North, which is our Institute of North Atlantic Studies. I'm actually, UNE is a partner in the COVID-19 response team, and that's how I've met many of you here already. A little bit about the University of New England. We are the largest private university in the state of Maine. Most of you know that Maine is our easternmost state here, and we have very much more in common with the North Atlantic and Northern Periphery countries than we do with most of our neighbors to the south. University of New England is a comprehensive university with a specific focus on the health sciences. So we have the only medical college in the state, the only dental medicine college in the state, as well as programs in 16 allied health professions. And we're the largest provider of health professionals to the state of Maine. My interest in this, I come from a slightly different angle. I'm a public policy and education PhD, and so I will offer a little bit of a different perspective here. But I'm very excited to be part of this group because in my role of UNE North, we look to build partnerships throughout the region to leverage our strengths at the university to solve some of these very common challenges and opportunities that we have as rural northern countries and states. So with that, I will hand it over to the next panelist.
Peter, would you like to introduce yourself?
Yes, I hope you can hear me, hopefully.
Yep.
My name is Peter Nordstrom. I work as a professor at the geriatric clinic at University Hospital of Northern Sweden in Umeå, that is situated about 300 kilometers south of the polar circle in Sweden, so it's in the north of Sweden. I've been professor at the university for 10 years, where I work with predominantly health investigation of all 70-year-old men and women living in our municipality that consists of about 130,000 people. Within this context, I've been working with wearables and accelerometers in particular, where we have investigated the association between objective measures of physical activity and outcomes such as especially falls, but also cardiovascular disease and death. Except for that, I work a lot with emerging different nationwide resources for epidemiologic data that we have in Sweden, such as national patient registers and such things. I think that's it.
Thank you. And Dr. McEwen, if you'd like to introduce yourself.
Hi everyone, so my name is Jason McEwen and I'm a medical doctor from the UK, so practiced mostly in kind of neurology and neuroscience for a while. And then on the research side, I got invited out to University of California
in 2015 to study under a guy, Ramachandran, looking at non-invasive neurostimulators, so essentially wearable devices. And then in parallel to that, still on the research side, I have a position at UCD in Dublin at the metabolic research. They're looking at type 2 diabetes, and then I also do research at Queen's as well, looking again at type 2 diabetes and obesity. Then on the more commercial side, because of the non-invasive wearables that we created, I then set up Neurobalance as a Belfast-based medical device company a few years ago. That's been largely successful for us. We've raised maybe about $15 million or so in funding. We've sold maybe about 13,000 wearables right across the world. And at this stage, we primarily focus on non-invasive treatment of insomnia and anxiety on the neurological side. And then on the metabolic side, our interest is really type 2 diabetes and metabolic disease.
Perfect, thank you. And it's interesting to hear that not only is there there's sort of monitoring wearable technologies, but also moving through into the therapeutic space as well. So hopefully we'll hear more about that. Professor Timmons, welcome. Would you like to introduce yourself?
Sure. So I'm Suzanne Timmons from UCC, so that's where Tyndall is also based, but I'm in a different school and centre, the Centre for Gerontology and Rehabilitation. So I run a master's in older person rehabilitation and also in dementia. And academically, I suppose my interest is in anything to do with older people, but particularly Parkinson's disease and dementia, including health service research, tool accuracy, you name it, if it relates to older people, I'm interested in it. And then clinically, I work in acute hospitals, residential care, and in the community, including inpatient rehabilitation wards. And again, I run a movement disorder clinic, and I see a lot of people with dementia, but again, older people with lots of conditions. And I'm the clinical lead for the National Dementia Office for our health service. So I know a lot about policy and practice and the challenges of translating research into actual clinical practice, but then actually into higher level policy. So, you know, I was involved in SENDoc kind of as an academic and as a clinician. So it's funny to see it from both sides because your needs are so different depending on which hat you have on the day.
Perfect, thank you. And I think you've highlighted we need to pull together people from many different perspectives, and so I'm delighted that we've got that clinical research, commercial and policy mix on this panel. We've already heard from the previous speakers about how rehabilitation is probably going to move now into 40% face-to-face and more into the remote space. So I think wearables are and that monitoring and patient contact is extremely important and accelerating. We've also heard previously that age is irrelevant. And also the other piece that I picked up as well was that we need accuracy, not just in one parameter, but we actually need to think about accuracy across multiple parameters. So I think the first question I've got for the panel, and I'm going to start with Jason, is how accurate does a device have to be useful clinically? Can you comment on that?
Yeah, it's not a straightforward answer, but I'll try and keep it as concise as I can. I suppose one viewpoint that we have, which is different actually than when most people think of a wearable, is you've already touched on this. We have a therapeutic device, so we make totally non-invasive wearables, but they don't measure anything at all. They actually put electricity into your brainstem. And whenever it comes to accuracy, actually, you then certainly on our side, what we find is we really have to think about the stakeholders and who you mean when you think of accuracy. Is that the same as efficacy, or is it some other metric that an end user wants to see? And the reason that we spend a lot of time looking at this actually, and if you think about, say, a drug or an implanted device, there's a process there that a user goes through, which is, you go and see your doctor and you're told about your treatment options and you're told about the risk benefit ratios and the side effects and what to expect. And actually, if that device, say, doesn't deliver what you expect, or it's not as accurate as you hoped it was going to be, well, then you usually move on to something else. And then through that process, eventually you'll get treated, and you as a patient are very happy, and your physician who is treating you is also very happy. But Fast forward to now, when you're getting non-invasive devices, which some of them are so low risk that they're effectively almost consumer health devices, and that changes it entirely. Because if I said to you an implanted device, for example, is 1 in 5 times it'll deliver exactly the outcome that you want, that's like a medical miracle. I mean, if you could cure 1 in 5 diseases with every time guaranteed with a device, you'd be very, very happy. But if that device were an iPhone, and I'm saying to you 4 out of the 5 iPhones that you buy are actually going to end up in the bin and they don't work, well, then you're going to have a really, really upset end user. So when it comes to things like defining accuracy, the way we would look at it is we want it to be ultimately as accurate as we make the claim to be. And that is something that we engage with the end user so they have expectations, or they have the right expectations. It's something that we engage with the physicians, but ultimately it comes right up to things like, even when we're speaking to NICE and the FDA and the insurance companies, so that everybody is just absolutely aware what to expect, I suppose. So I know I haven't given a very sort of defined answer there, but in summary, as I say, the accuracy really just depends on what you are claiming it to be and what users, in our experience, what the end user expects to receive.
That's fantastic. So in summary, your answer is it depends. Love it.
Yeah.
Okay.
That's it, yeah.
Peter, I wondered if I could bring you in here from the clinical perspective about, clinical claims, and for things to be useful clinically, how accurate would you expect them to be?
Well, I would say one thing is how accurate the device is, but I think a more important thing is whether the device you are using actually predicts disease. If there is disease that you want to predict. I mean, it's difficult to give a number. Of course, the more accurate device you have, the better, but you need also to address whether this device is acceptable to wear for the patient. If you take accelerometers, they are of course very accurate and they are not difficult to use if you just want to measure steps per day or wear time or whatever. But I think it is kind of a set off where you need to consider both the accuracy and that this specific device can predict disease, and that it is acceptable both for the healthcare and for the patient.
Yeah, I think that's a really important point, is the different stakeholders. Suzanne, can I bring you into this?
Yes, so I'd actually echo what both of the others have said, but maybe to kind of use an example, if I was going to start anyone listening on medication for high blood pressure, you'd all want to know that it was based on a test on a device that was really accurate. You would hate to think that I would make a diagnosis of high blood pressure based on a faulty device or a not so accurate device and expose you to the risk of medication that you'd be taking for months or years that could cause serious harm. So when we're making a diagnosis of yes or no, start treatment, don't start treatment, we want our device to be super accurate and we want it to be approved by regulators, and it has to be, I don't want to say 100% accurate, but incredibly accurate. Whereas if I was seeing somebody, say with Parkinson's or dementia, and they had fallen and there was something about the history that made me think it was a blackout, that their blood pressure had dropped, I want a device that reasonably shows me that at the time their blood pressure dropped. But I actually don't mind whether it dropped by a huge amount or a large amount, or 50 millimeters or 55 or 60. That's not relevant. I want to see a reasonable kind of proof. Or the same if you were thinking that somebody's at risk of falls. It doesn't matter that they are 4.5 times more at risk than someone else or 5 times, because the treatment you're giving is not a yes or no. They're at risk, and exactly how much at risk doesn't matter. So my thinking is that how accurate I need to be depends on the action I'm going to take. And if it's an important action like exposing you to a risk, then I want it to be very accurate. Whereas if it's part of a bigger picture and it's just swaying me a little bit, then I can take, it being less accurate. So I hope that's helped people see how I'd kind of see it.
So far we have 3 answers of it depends, it depends, it depends on your patients, on your stakeholders, on what you're trying to measure, and whether you want just a look-see at cause and effect, or you're actually trying to diagnose a disease. I think it's a really useful conversation. Holly, is there a policy perspective to this about how we need to pull that through? Or
well, I think what was striking me in those 3 answers was really the issue of educating our practitioners in terms of how do we build trust around these new technologies, and how do we, for instance, with our students at UNE, we train them in terms of interprofessionalism. So sometimes the person who's delivering the message to the user about a technology, you may be working in teams where a social worker is working with a family to help them understand the role of the technology, as well as to build trust in the accuracy of that technology. And so I think it's really interesting to kind of, this idea of trust was underlying all these decisions, and how we build that trust based on the individual needs of the user. Right. And so for us in Maine, where we are not as advanced in using, frankly, some of these technologies as I'm hearing here today, we need to work to re-educate both our current clinicians and how to talk about technologies and some of these technologies with their users and their patients, but also our students who are currently coming up through our trainings, understanding how you can use a team-based approach to really build that trust around technologies. So that was a big piece. And on the policy side, you know, how we communicate with policymakers is different than how we communicate within research communities. And so understanding the language that policymakers need to have at their fingertips to make decisions, be it an insurance company, be it the FDA, be it congressional delegations that are trying to allocate funds for new technology development. We need to understand the language that they need to hear and move outside. And we find that a bit of a challenge sometimes in academia to speak outside of that realm in an effective way. So those are the 2 pieces that kind of sprung to mind when I was hearing that.
Thank you, Holly. So that's another it depends, but fantastic. And you've actually moved us on of one of the next questions that I was really keen to hear, was really about, if I could ask each of the panel members, and I'm going to come to you first, Peter, about what are the key challenges you think that we need to address to get wearables used more by clinicians? If you could comment on that, please. Peter. I think you're on mute still, Peter.
Oh, now you can hear me.
Perfect.
Can you summarize the question again?
Absolutely. So really thinking about moving through to accelerate use of this in the clinic, what would you say the key next challenge is to get wearables used more by clinicians?
Yeah, I think for me, the key challenge would be the tech barrier. And reasonably, it is a tech barrier both within healthcare and for the patient. And my guess is that this tech barrier is higher in older patients, both due to the fact that older patients may not have been included into the tech revolution, and perhaps also the older patient have cognitive deficits which make these kind of wearables more complicated for them to use.
Thank you. And Suzanne, can I bring you into this, because you particularly focus on cognitive decline as well? Is that something you would echo, or do you have another key challenge?
Yes, well, just thinking about the users, first of all, the person wearing them, I do think we have to be careful to appreciate that a lot of older people do use technology and can use technology. And we've certainly used, say, iPads with people with mild dementia, and they've learned them really easily. So I think we have to be careful not to assume you need a lot of tech knowledge. There certainly are challenges. I mean, as you get older, a lot of times it's practical things like putting on and off a device, seeing the screen, you know, if it's a dark background and dark colors, if it's fiddly, if there's a button you're supposed to push, but you can't, you've arthritis this and you can't push it. So I find a lot of times it's not so much the cognitive challenge, it's often motor dexterity and small things catch people. But certainly the device has to be usable for a person. If it's very complex, then there has to be a lot of simple instructions and there has to be support for the person. And I suppose as much as possible, not just for older people, there's a lot of people who would have particular challenges with technology. So we should try to make it as user-friendly as possible. But I would also say let's not be ageist and let's not assume just because someone's older that they can't. You know, they may well surprise us all.
Yeah. Thank you, and you've picked up that came through very strongly from the previous session as well, that age is irrelevant and it's the integration that it's important and thinking about those ergonomic factors. So, you know, I think we've heard that message loud and clear, so that's excellent. Jason, I wondered if you could comment really, if you're thinking about key challenges that need to be addressed to get the technology used more, is that something you do from a commercial perspective or in your academic work, thinking about the training that needs to come alongside you know, these new devices?
Yeah, I would say on the commercial side, because you know I totally agree with the points made previously, but I suppose looking at it, you know, from the commercial side, then there's the added challenge, and you know, ultimately for us, yes, you know, just making something commercially viable but I don't just mean the cost of the actual piece of hardware. I mean, even the physician's time and effort, and from an education point of view, from then they go on and educate the patient, and then actually seeing, does that have a big enough impact on the disease that versus the time and money that was spent actually, you know, getting that wearable into the whole treatment pathway. And for us, like, for example, you know, we're looking at type 2 diabetes. So, you know, the first line treatment for type 2 diabetes is metformin, which has been around forever and is extremely cheap. So it's a hard sell for us to go in and say, well, do you know what, we want you to look at this piece of technology, which is new and expensive instead. So I think there has to be a real balance there, not just on the commercial side for the companies that are making the devices, but also, as I say, for the physicians and even into things like patient time.
And thank you, Jason. I think that's raised an important point, and I've noticed times against us. So Holly, I was going to give you the last word, almost thinking about that sort of, I don't know if you might have a perspective on the payer and insurance side of that, you know, about and you could comment about adopting new technologies versus tried and tested maybe treatments. I don't know if you could comment on that.
Yeah, I mean, I would say that in the US, we have a very complex private insurance healthcare situation here that up until COVID had been really reluctant to make a lot of moves to allow for technology to be used in really creative and innovative ways in healthcare. I will say this for COVID as kind of the disruptor of the age. It has allowed us to move policies forward to embrace e-health, digital health in ways that we hope will remain after COVID. You know, we hope those policy changes not only remain, but they expand as people see the value of digital health and e-health. And just to speak a little bit to what we were talking about earlier, you know, I absolutely agree that we don't want to be ageist about the adoption of technology. For us, the problem here in Maine is actually broadband access. And that has been a limiting factor for our aging population, not their ability to use the technologies, but their ability to actually access it and use them in their homes. And again, that has been a policy change that we've seen with just in the last 9 months, is a huge demand to increase access to broadband, not only to make health care access more equitable, but education and economic opportunity. So those are some disruptions that COVID has given us that for better or worse, we hope we see them move forward, and we think will really accelerate the use of digital technologies and technologies for healthcare.
Perfect, thank you. And I'm really sad that time's against us here because there's a huge amount of conversation I think that still needs to be had in this. And I hope actually that we can organise a follow-up event or something where we begin to explore this further. and hopefully for the SENDoc programme, as that maybe, and Joan will tell us later if that continues, there might be the chance of an in-person event at some point where we can actually explore this over a glass of wine or something as well, or juice. So I just wanted to say thank you very much to the panel. Really interesting discussion, and we've learned that age is irrelevant, I think, which is fantastic, and we need lots of stakeholders on board to give their differing perspective, and it depends what you're trying to measure. Yeah, thank you to the panel, thank you to the speakers for some fantastic talks about research, and also to the organisation. Joan, can I hand over to you for your final thoughts?
Yeah, thank you, Joanne. If you could stop sharing the screen, James. Okay, yeah, thanks. So I have a couple of brief summary slides here, just so from the speakers, first of all, slide. Yeah, so we had Daniel, Carol and Ricky from Ulster, 3 case studies, fall risk prediction, spinal mobility and gait. And I think the key coming out of that discussion was that we need to be careful how we convert the data towards accurate clinical meaning. So we need to use the data to predict and also to analyse what has went before. From Auntie and Corellia, there near Santa, Auntie talked a lot about the barriers, and Auntie and I have discussed this offline many times. So security, accuracy, usability and cost. We need to carefully consider the context of the use. So not every wearable fits every situation. And patients and clinicians need to have that support in rehabilitation and technology. So some kind of hybrid model that allows the patient to be supported as well as the clinicians. We need to be sure that it's worth it. So don't just use a wearable for the sake of using a wearable. If it is worth it and increases the quality of life for rural elderly communities, then it's something that we should invest in. So onto the panel then, we had University of New England in the States, we had St Finbarr's in Cork and the Republic of Ireland, UMA in Sweden, and Neurovalence company in Northern Ireland. And one thing we mentioned here mainly is accuracy of wearables, and from the company perspective, the specific example was therapeutic device, and they need the wearable to be as accurate as it needs to be. So it's about managing the end user's expectations in terms of the device, whereas in the clinic, it depends on the need, and you need to balance that risk versus the treatment. If it's high risk, it needs to be really, really accurate. If it's low risk, then the clinician makes a decision as to whether it's doable. How do we get more clinical use? There definitely is a need globally, right across all our partners and panels here, to build trust in the technology, to understand what policymakers need to know and need to understand, and learn their terminology. We in academia in particular have our own language. My husband constantly complains that I speak in acronyms all the time. We need to simplify the technology, wearable technology, and consider co-design with clinicians and with end users, with the patient groups. And it's something we will probably look to do with dementia and Parkinson's, particularly in Ireland. The device needs to be physically usable by patients. So whilst we're not ageist, we need to be aware that older people do have mobility and dexterity needs that we need to take into consideration. Obviously, for companies, it needs to be commercially viable, needs to have value clinically and be worth the effort and make an impact on the patients' lives. In terms of new versus old, so pre and post COVID, it's been an awful year for most people. We're trying to stay positive as we race towards Christmas. A particular example in the States was given by Holly, where they have quite a complex insurance system, but insurance companies seem to be moving, and policies towards more wearable usage are certainly considering them. Broadband access can be a big problem. I'd just like to say before I close, Kirsty mentioned David Heaney, and I haven't mentioned him at all. To date, I wanted to leave it to the end. I'd like to thank all the panel, Joanne, Kirsty, the SENDoc wider team. David was part of our SENDoc team, and we unfortunately lost him in July. He was a really good friend, and he would have absolutely loved these webinars. He was really appreciated in the NPA program, had done many NPA projects and brought me into the NPA program. So if you could just keep an eye on the website for updates. We will also upload these 2 videos, and my email address will be on there as well for contact. So I hope everybody has a happy and safe and healthy Christmas, and thank you all for attending. Thank you.
Thank you.
Thank you.
Thank you.
Thank you. Bye.
Happy holidays.
Happy holidays.
Happy holidays.
Bye bye.
Bye.